Good morning, everyone, and good evening, depending on where you are in the world. My name's Jason Roberts. I'm from the University of Queensland and the Royal Brisbane Women's Hospital, and it's my pleasure to open today's Therapeutic Drug Monitoring Virtual Symposium. This is a collaboration between the University of Queensland and more specifically Centre of Research Excellence, REDUCE, which is a research centre that I'm fortunate enough to be the director of, and also CHU NIMS, which is a very strong collaborating university hospital in the south of France. That, as I said, that we're very proud to collaborate with, and they've worked with us to develop this very nice program for about the next 12 hours. So as you all know, and the reason you're joining this is because antimicrobial therapeutic drug monitoring is something which you're interested in, and there has been a lot of new information that has emerged on this in recent years, and including major position papers and key clinical trials, and all of these are worthwhile reflecting on and sharing over the course of the various presentations that there will be today. Some of our speakers will be present in person here at UQCCR, which is the University of Queensland Centre for Clinical Research in Brisbane, Australia, but others will be joining virtually, and so they'll be Zoom speakers, just like you are. Many of you are Zoom participants. The structure for today's symposium is that we'll start with initially the first session relating to dose optimisation and PK/PD, and you'll note that all the presentations are quite short and sharp, so 20-minute presentations. There may be some scope for question and answers, which I hope there will be that will be able to occur, but we'll try very hard to state a time. But if you do have questions, please put them onto the Q&A bubbles which you can see on your screen. The second session after morning tea will be about some concepts and around therapeutic drug monitoring. The third session will focus on dosing software. Now, I will highlight the fact that there is a specific dosing software that will be the focus of some of the presentations in this session, but it is just one example of a dosing software. There's lots of dosing softwares out there, and we just chose this one because it's one that we're familiar with. But there are many other softwares which are available, and each of them perform very well. So I'm not necessarily suggesting that we are advocating for this above others. And then after the afternoon tea break, there's going to be some case studies where we work through some examples of vancomycin and meropenem with that dosing software. And then after the dinner break, we hand over control to our friends in France and Dr. Claire Roger, who's an intensive care physician at CHU NIMS. She'll be take control of the meeting from there, and you can see that we have some really quite eminent presenters from Europe as well contributing. So across the day we have, we're very happy with the people that have agreed to speak at this meeting. I think that they're all fantastic experts who have wonderful insights for each of the different topics that they're presenting on. I think that we're very fortunate that we have a wealth of knowledge that we're able to tap into in Australia, but also from our overseas friends as well. And so we're most grateful for that. I'd like to highlight that Pfizer and MSD are the sponsors for this meeting, and we're very grateful to Pfizer and MSD, who continue to be very strong supporters of the education programs that we try to provide to our colleagues in Australia and internationally, and we're very thankful to them for that. And Dr. David Grohlman, who's medical director for Pfizer Australia infectious diseases, he'll be giving us a short 5-minute presentation in just at the beginning of the lunch break, just to let the audience know about some of the new initiatives coming from Pfizer. And so we look forward to hearing from Dave then. Before we start the next session, I just wanted to let you know that Many of you will see that there's 115 participants that are currently online, but we have had over 550 registrants, and they come from over 25 countries. And the likelihood of that growing throughout the course of the day is, of course, quite high. I would emphasise that all of these presentations are being recorded, and they'll all be made available to any viewers who want to log into our CRE Reduced website, where we have access to our YouTube channel, where people can access not only the presentations from today's symposium, but also from many of the previous seminars that we've organised over the last 5 years. So with that, I will welcome you all once again to this symposium. It's an absolute pleasure for us to put this on. It's a topic which is near and dear to my heart, and obviously to many of the others that are presenting, and also for those of you that are listening and hopefully will be participating through some of the questions and answers. So now I am going to put on my slides for the first presentation of the day. So I'm going to lead off today. I'm chairing this first session as well, so naturally I gave myself the opportunity to speak first and get that out of the way. And I'm going to talk about the need for antimicrobial dose optimisation because, of course, in the context of therapeutic drug monitoring, what is most important is that there is some reason for why we have to change doses. And so that whole process of changing doses is really to optimise the exposure of antibiotic or antimicrobial that is being given to a patient for some sort of clinical benefit, which may be related to an increased likelihood of clinical cure, decreased likelihood of drug toxicity, or even suppression of emergence of resistance. I just have some disclosures that I'd like to make there. So the contents of what I'll be talking through in about the next 20 minutes is to discuss why effective antibiotic dosing is important, and obviously we don't need to spend too much time on that because all of the participants here will be fully aware of most of those issues. Then to talk about PK/PD, the effect of exposure on emergence of resistance, some clinical outcome data, and then of course some conclusions. Now this is going to be a very high level talk because as you'll see through the program, on some of these topics there will be other speakers that will go into these issues in a lot more detail. Where I will focus a little bit of time is on the clinical outcome data because I think that they show from a quantitative perspective why optimisation of dosing is important and what difference it makes to patients. So this is a slide I'm sure many of you have seen, and it really is trying to define what the interaction is between patients, antimicrobials and pathogens, and how that interaction influences each other and can determine whether or not the patient is likely to manifest a positive outcome. So if we think about this, these three players, if we could call them, in the treatment of infection, and what we can control as clinicians is really that we can control the drug. We can't control too much about the patient because they are what they are. They have the comorbidities they have, the pathophysiological changes that manifest as part of their disease process from which they've developed their infection, but we can control the drug. And so this is where that issue of dose optimisation becomes something which is quite important because obviously drug choice is something which we have a lot of control over, but also the dose of drug, the infusion duration, the frequency with which it's given. So each of these are controllable factors for us. For the patient, as I've mentioned, there's not too much that we can do there except source control, of course, which is of fundamental importance to treatment of infections as well. But we don't have much say over what kind of pathogen, of course, is causing the infection. And so in terms of the patient and the pathogen, we have those presented to us as clinicians, and then we have to design what we think is the best therapy for patients. So if we are not successful in choosing an accurate exposure of drug, and this is what, of course, we always aim to do when we choose a dose of drug, to choose a dose which is going to be effective. If we aren't successful in doing that, then that can lead to therapeutic failure. And I'll show you some examples of some prominent phase 3 clinical trials where this has occurred. There is also a high likelihood that it can lead to emergence of resistance, although the clinical data supporting this isn't strong, but the in vitro data is very strong, and it can also lead to drug toxicity. What each of this means is that there really is a very strong concentration-effect relationship that exists for antimicrobials, and that small titrations and exposure of drug can greatly influence what the outcome of that treatment is going to be. And so dosing, of course, is of fundamental importance to control what those exposures are. So why this is important is that although we should be very grateful to the level of regulation that there is in the drug development process and the amount of money that's invested in that process to try and ensure that dosing regimens that are included in drug monographs are as safe and effective as possible, we all know that drug dosing studies aren't done in many of the patient groups in whom those drugs end up being used. If we were to ask companies and our regulators to delay launching of drugs until we had all of that information, then of course we'd be depriving many patients of potential use of those drugs. And so that's why post-marketing dosing studies are quite important. But one thing that is very clear, though, is that these preclinical dosing studies, which I've got indicated here by the presence of these animal infection models, they're very good for identifying what exposure of drug is associated with maximal efficacy for an antimicrobial. Once we have this information about what exposures are appropriate, then some pharmacokinetic studies can be done in healthy volunteers to work out what kind of doses should be used in patients to ensure that we're achieving these exposures associated with optimal efficacy. And then typically the phase 2 and phase 3 clinical trials are performed in relatively contained cohorts of patients which don't reflect the broader population in whom those drugs may end up being used. And so whilst they're valuable and they're an important starting point, that these dosing regimens which get validated in these clinical trials, they aren't necessarily reflective of all the different patient groups. And that's why this focus on using different doses and optimising doses is important in some patient populations. So in order for us to make decisions about how we optimise dosing, then we need to have some understanding of the PK/PD of antimicrobials. And this is a topic which other speakers will go into in a lot of detail. But the only point I wanted to make at this time, in the context of the importance of dose optimisation, is that these exposure-effect relationships have been very well defined. And you can see on this particular slide from a paper in Critical Care Medicine in 2009 that there are 3 essential classes of antimicrobial from a pharmacodynamic categorisation perspective. There are time-dependent antibiotics, concentration-dependent antibiotics, and then those that are more of an AUC-MIC. Note the importance of the MIC here. It is the denominator in each of these different relationships. And so when we talk about the need for dose optimisation, we obviously need to be thinking about, well, what is the pathogen causing this infection? How susceptible is it to the antimicrobial, and is it at a predictable level whereby we can use a normal approach to dosing, or has it actually changed itself, which may mean that we need to optimise dosing because of that MIC. In terms of pharmacokinetic issues, of course, in each of those PK/PD indices, the numerator in each of those indices is a pharmacokinetic numerator, which means that it essentially defines what exposure of drug is important in that index. And the main point I wanted to make here is that there's a whole spectrum of pharmacokinetic possibilities which can occur. This specific graphic here relates to critically ill patients, but really the breadth of possibilities from a pharmacokinetic perspective and drug exposure perspective are very broad. And if we think about the kind of patients that we will see on a singular ward, they can encompass each of these different manifestations. And of course, that can then lead to different exposures. And so each of those patients, because of their different presentation and the effect that that has on pharmacokinetics, often will mean that many of those will need different doses to one another. Again, this is a topic which others will go into in more detail later. I referred earlier to the importance of understanding the MIC. And this is something which is of quite fundamental importance, and particularly in some parts of the hospital where you're more likely to come across patients that have either a greater level of immune suppression, perhaps more likely to have recurrent infections and previous antimicrobial use, and therefore there has been this opportunity for emergence of more resistant bacteria to come through. And one of those areas is the intensive care unit, but it's not just the intensive care unit. It can be patients that are long stay in the surgical wards. It can be patients that are in transplant wards, burns wards, any place where there are long stay patients where they're likely to have multiple infections. This is certainly the case. And I just wanted to highlight the point that in surveillance studies, and this example here is from comparing MICs for carbapenem antimicrobials to pathogens in ICU patients versus ward-based patients. Essentially, the MICs were 2 to 3-fold higher in the ICU, suggesting that not only is there this altered pharmacokinetics that we need to be thinking about, but also thinking about what is the susceptibility of the pathogen. Because, again, from a dose optimization perspective and staying true to those pharmacodynamic principles which define what is that maximally effective exposure of dose to achieve, then we need to be thinking about what is that MIC denominator in the PK/PD index. An example of where this has been shown to be a topic which we don't do very well in medicine is this data from the dali study. So the dali study was a point prevalence pharmacokinetic study that many of you will have heard about. It was published in 2000 and it was run in 2010, 2011. And what was observed in this study is that there was up to 1,000-fold variation in PK/PD exposure of these drugs. So if we think that as clinicians, we're trying to make sure that all patients achieve what we would consider to be an effective exposure, which typically would be an exposure within a therapeutic range, which is not too small and not too great, so not too small so it's going to risk failure, not too great so it's going to risk toxicity. We can see that we don't do that necessarily very well. And something that was clear in this study is that if you didn't achieve what we would consider to be the most conservative target from a beta-lactam exposure perspective, then those patients were more than 3 times more likely to fail treatment. So I want to touch a little bit about this issue about the effect of exposure on resistance because, again, from a dose optimization perspective, this is a very important concept. But it's something which is very difficult to study in a clinical scenario. And so often we are reliant on trying to understand mechanistically what is likely to happen with this interaction of drug and bug through use of really sophisticated in vitro models. And so this is a study which we were fortunate enough to collaborate with Cornelia Landersdorfer and Phil Bergen from Monash University using their in vitro infection model, which is called a hollow fibre dynamic model. With this model, essentially it enables the modulation of concentrations to match exactly what you want it to be. And so in this specific study, we modulated the concentrations of antimicrobial, in this case piperacillin, to be what is observed in critically ill patients at different levels of renal function, 30, 110 and 250 ml per minute. Against a Pseudomonas aeruginosa isolate over a 7-day period of time. So measuring it over a 7-day period of time is really important because that's a clinically relevant duration of therapy. Now I'll walk you through this graphic in a little bit of detail to make it clear. So on the y-axis of each of these 3 graphics is log 10 CFU. That's essentially bacterial concentration. And the lower the concentration, that means that there's been some form of bacterial killing. The higher means that there's been bacterial growth. X-axis is time, and then each of these 3 graphics is a creatinine clearance of 30, creatinine clearance of, it's sort of blocked out here, I think it was 130, and then 250 ml per minute. And then each of the different coloured lines represents, here the diamonds represent no drug being present. So with no drug being present, of course, you'd expect to see a growth of bacteria and very high exposures. And then with these different doses, with different renal function, the different renal function, of course, as it increases, it'll reduce the overall exposure of antibiotic. What was observed here is that, that there is a threshold whereby if you achieve a certain exposure of piperacillin to this Pseudomonas aeruginosa isolate, then you can suppress the emergence of resistance. But that's very difficult to do at very high renal functions because, of course, you get such rapid clearance of the drug that there's very little of the drug present to enable that suppression of resistance. But what we did find in this is that a trough concentration greater than 5 times MIC was required to suppress emergence of resistance. So, as I said, there hasn't been much clinical data on this because it's very difficult to perform those studies, but in a very controlled scenario, we were able to show exactly what that relationship is, and there's been many studies on that now. In terms of the clinical data, which is supporting optimal exposures, this is a table which summarises some of the data that exists. And the main point I wanted to make here is that almost all of the antimicrobial classes are covered here, which means that this clinical outcome data supporting a particular exposure of drug being associated with better patient outcomes has been described for each of those different antimicrobial classes. For beta-lactams, which are time-dependent antibiotics, there's many studies now which are showing some of these results, and I've listed some of those on this slide, and I won't go into them in any detail, with the exception to say that what is more commonly observed in these clinical studies is that a slightly longer time above MIC has been found to be associated with optimal effects than what has necessarily been shown in vitro, which is a curious finding because it doesn't necessarily exist the same way for other drug classes, but nevertheless, that's what the clinical outcome data suggests. Again, that there is a exposure threshold whereby patients are more likely to do better. Again, supporting that need for dose optimisation to achieve those exposure thresholds. In terms of mortality data, well, one method of optimising beta-lactams is through use of continuous infusions. And there's obviously some large research studies that are going on at the moment, including the BLING-3 study, which is being run from the University of Queensland in conjunction with the George Institute throughout 7 countries around the world. This is data from an individual patient data meta-analysis, which provided some of the statistics to guide the sample size calculation for BLING-3, and essentially was able to show that of all of the randomised controlled trials that was done meeting a certain criteria, that there was evidence of statistically significant as well, that a continuous infusion, so a form of dose optimisation, was able to reduce hospital mortality in critically ill patients. In terms of aminoglycosides, this is a randomised controlled trial performed in the late 1980s, published in the early 1990s, which essentially showed that if you use once daily aminoglycosides, whereby you're more likely to achieve a higher peak concentration, which is being true to the pharmacodynamic characteristics of this drug, then you are more likely to have higher clinical cure, higher bacteriological cure, as well as reduce incidence of renal dysfunction compared with twice daily dosing. So effectively, with the same dose being given over the day, you should get a very similar area under the curve, but it shows that the importance of the peak concentration. So again, another form of dose optimization, better outcomes for patients. For quinolones, this was essentially a post-hoc analysis of some pharmacokinetic data that had been collected up in the USA by Alan Forrest and Jerome Shentag, indicated that with their logistic regression analysis, that an AUC-MIC greater than 125 had a far higher likelihood of clinical cure and bacteriological cure. I wanted to quickly go through 2 examples of what happens when dosing is not optimised. The first one I want to spend a little bit more time on. So in this particular study, this was an expensive phase 3 randomised controlled trial comparing a microbiologically superior doropenem versus imipenem for treatment of ventilator-associated pneumonia. Interestingly, this trial was terminated early, halfway by the Data Safety Monitoring Board, because clinical cure rates were found to be far lower in the doropenem group. And when inspected for why this was the case, it was just the fact that patients with an increased creatinine clearance had lower drug exposures than those for imipenem. And so because dosing of doropenem hadn't been optimised, then that is the reason that this drug failed. And so that's a cautionary tale of why it's very important to have dosing which is specific for the patient population. And critically ill patients are of course, a different patient population to others. This is another study just demonstrating in the presence of augmented renal clearance, a higher renal function, can be observed commonly in critically ill patients, that there's an increased likelihood of failure in those patients with augmented renal clearance because more drugs being cleared, less drug present in the body, it's less able to elicit its microbiological effects. In terms of data of TDM, given this is a TDM symposium, I'll refer you to a position paper, which many of the speakers I think will refer to later today. This is a table which highlights some of the clinical outcome benefits of TDM-based studies. And there are two of these studies in particular that I wanted to highlight. The first is by Van Lantevers from the Netherlands of a trial comparing aminoglycoside and a very sophisticated therapeutic drug monitoring versus a non-guided therapeutic drug monitoring, so the intervention wasn't quite as active. And what was observed in this particular study, when of course aminoglycosides were used a lot more differently to how they are now, is that you could dramatically reduce length of stay with better treatment of infection through this active therapeutic drug monitoring approach. Nephrotoxicity associated with the drug was also decreased, and there was also a numerical decrease in mortality, which didn't quite reach statistical significance. Another study from Daniel Richter in Germany in collaboration with the Heidenheim group, who do a lot of fantastic pharmacokinetic studies looking at beta-lactam therapeutic drug monitoring, essentially found that if you achieve concentrations between 33 and 64, then you have much lower mortality rates than concentrations either side of that. What about drug toxicity? Well, of course, this is a very important consideration as well. Craig McDonald, who was a senior registrar at the time at the Royal Brisbane Women's Hospital, performed a retrospective analysis and found that high doses of their own volition of antimicrobials don't lead to drug toxicity. Whereas a study from Fabio Tacconi and his group in Erasmus University Hospital in Belgium found that actually concentration is more important than dose itself, and was likely to result in neurotoxicity for patients. So in conclusion, I hope that I've set the scene for the rest of the day, that there really is a clear concentration effect relationship, and that optimisation of dosing is very important, not only to ensure clinical cure, but also to potentially prevent emergence of resistance, and also to ensure maximal safety of drug. The question is, should we be using optimised dosing? Well, I hope that I've made the case that this is important, and that you'll see through the rest of the day what options that we have to doing that, with, of course, that focus on therapeutic drug monitoring. If I was to then say, well, what do the international treatment guidelines say? Well, they would agree with a lot of what I've presented so far. And so this is the clinical practice guidelines for hospital and ventilator-associated pneumonia from the IDSA and American Thoracic Society in 2016, and it was one of their key recommendations that dosing should be determined using PK/PD data as opposed to standard dosing. So I'll thank you all for your contribution to the day, and I will call up the next speaker, who is Mr. Paul Williams.